Welcome everybody to the World Theragnostics Day webinar. I'm Kalevi Kairamo from Helsinki, Finland. It's snowing here, and we have a 5-year anniversary of the World Theragnostics Day, which was started 2019. The proclamation was 2018, and now we have a 60-minute webinar with two distinguished speakers. And the first speaker will be Professor Hossein Chadwar from USC. He's a professor of radiology, urology, biomedical engineering at University of Southern California, and he's been the fellow and past president of American College of Nuclear Medicine and Society of Nuclear Medicine and Molecular Imaging, and currently the president of SNMI Therapy Center of Excellence, and he also is the chair of the U.S. Nuclear Regulatory Commission Advisory Committee on Medical Uses of Isotopes, and also the director of American Board of Nuclear Medicine. And he has written more than 180 peer-reviewed publications, numerous Congress abstracts, and 4 books, 40 book chapters, 9 U.S. and European patents, and more than 300 invited lectures all over the world. And his research is focusing, besides translational molecular imaging, in prostate cancer theranostics and radiopharmaceutical therapy. And he will be speaking the next 25 minutes about the challenges of lutetium PSMA radioligand therapy in clinical practice, and the audience is allowed to ask questions by chatting during the presentation. Professor Chadwar, the stage is yours.
Thank you so very much, Kalevi, for that very kind introduction. I'm delighted to be participating with this webinar commemorating the World Theragnostics Day, especially in company of Drs. Scott and Kairimo, and of course my friend Josh Mailman in the control room. So as Dr. Kalevi mentioned, I'm going to talk about challenges with lutetium PSMA treatment. Hopefully I can share my slides in here. Do you see my slides? Kalevi, do you see my slides?
We do.
Okay, excellent. All right, so let's just start. So this is the outline of my presentation. I'm going to talk about some of the issues with patient eligibility, and I'm just going to talk about imaging part of it, not the other parameters that go into eligibility for patients who undergo lutetium PSMA treatment. Then I'm going to talk about some of the issues related to treatment dose or schedule modulations. For example, when do we decide to delay or give the patient a treatment holiday, reduce the dose, and how do we know to restart the treatment? Is it possible to intensify the treatment in some patients who may benefit from that, and how do we know that the therapy is failing and we should stop the treatment altogether, for example? A bit about response assessment and a very few note about retreatment that has been happening and the data on that, and finally on 2 issues of renal impairment that may be induced in this type of treatments, and then diffuse marrow disease and how do we deal with that. So let's talk about patient eligibility with, again, imaging focus. This is the rather busy slide showing you the treatment landscape of prostate cancer, which is becoming very complex and ever-changing. As you can see, the burden of disease is shown in that red color line for different phases of the disease. Here is the initial staging and typically treated with local therapy. Then We have biochemical recurrence, patients who may develop a metastatic disease, initially hormone sensitive, M0, and then become metastatic disease, again, hormone sensitive, and eventually transit into metastatic castrate-resistant prostate cancer. And you can see all the clinical trials that have been performed and resulted in approval of different types of treatments at different phases of the disease. As you can see on this right-hand side, these are the three lines of treatment, class of treatments for patients with metastatic castrate-resistant prostate cancer. And down here in the kind of a third line treatment, you see the VISION trial. That's where we sit right now with lutetium PSMA radioligand therapy. As you know, there are many clinical trials going on right now to bring this type of treatment in earlier stages. But for now, we are in kind of the last phase of the disease in metastatic castrate-resistant prostate cancer. Now, what about the imaging? So this is the molecular imaging landscape. Again, instead of showing you that red line of burden of disease, this is shown in boxes, but essentially it's the same thing. Again, the three phases of the disease, initial staging, biochemical recurrence, and metastatic disease. And you can see essentially across all these three major phases of the disease, PSMA is a useful and used molecular imaging modality. And now, of course, we have the gallium-68 PSMA 11 approved. We have the PYL approved, and also more recently the radiohybrid 7.3 approved. Also, you notice that in the metastatic disease phase of the disease, I also included FDG, and we're going to talk about a little bit about FDG and its potential uses because it has been used in some of the previous clinical trials. So let's talk about FDG. Some years ago, our group showed that FDG is a predictor of total time to hormonal treatment failure in patients with castrate-resistant prostate cancer. And the THTF was defined as time to change from ADT to chemotherapy or death. We defined a parameter called sum, which was very simple. It was basically the sum of the SUV max of the 10 most active lesions on FDG PET scan. And as you can see in this Kaplan-Meier survival curves, if you put the sum parameter into different quartiles, you can really separate the patients quite nicely with regard to who's going to develop a hormonal treatment failure as opposed to some people who will be much faster transiting into the castration-resistant disease. Similarly, if we look at this in the group of patients who have metastatic castrate-resistant prostate cancer, and we look at the outcome of overall survival, again, the same parameter sum, we showed that, again, when we put this in different quartiles, it is possible to use FDG PET-CT information to predict the overall survival in these patients. In fact, if the sum was over 20, the hazard of death increases dramatically. So FDG PET-CT is actually useful in metastatic prostate cancer. And in fact, the FDG was used in some of the previous clinical trials. So here's a LuPSMA that you all know about. This is from Dr. Hoffman's group at Peter Mac. At that time, they looked at 30 men with metastatic castrate-resistant prostate cancer. And the outcome was PSA 50% decline in PSA from baseline. And they noticed that in about 60% of these patients. However, for the eligibility to enter into this phase 2 study was patients who had PSMA positive disease on PSMA PET-CT, but there should have been no FDG positive disease. In other words, the patient should have no FDG positivity. Similarly, the same group, again from Peter Mac, in their another clinical trial that they were involved with, the therapy trial that was published in Lancet in 21. This trial compared cabazitaxel, which is a second-line chemotherapy in the patients with mCRPC, with lutetium PSMA. And in this case, the PSA 50, again, 50% decline in PSA from baseline, was shown to be more in about 66% of the patients with low PSMA, as opposed to 44% only in cabazitaxel. Also, the adverse events was fewer in the lutetium arm compared to the cabazitaxel arm. However, again, just to remind you that in this case, the inclusion criteria was that there should have been no FDG positive and PSMA negative disease. Then we come to the pivotal phase 3 study, randomized phase 3 study that was published in New England Journal of Medicine, the VISION trial, which basically compared the best standard of care with which allowed some treatments and did not allow some other treatments to the active arm, which was lutetium PSMA 617 plus best supportive or standard of care. And the bottom line here was that there was 4 months overall survival benefit in the experimental arm or the active arm, and 5.3 months benefit in the radiographic progression free survival. But if we compare how the patients were entering into these trials, we can see there were differences between these 3 major trials that incorporated lutetium PSMA. In the low PSMA trial, again, they did FDG scan, and there should have been no FDG positive disease. And then they defined PSMA positivity when the SUV max of the lesion was greater than 1.5 times the liver SUV mean. So they used a semi-quantitation in here. And using this criteria, they excluded 16% of the patients. In the therapy trial, it was a little more strict in who was actually getting into this trial. First of all, there should have been at least one lesion with greater than 20 SUV max. That was a pretty hot lesion. And then all the other measurable lesions on CT should have had SUV max greater than 10. Again, no FDG positivity. This excluded almost a third of the patients and basically enriched the pool of patients for positivity in the trial. On the side, I would mention in a later study that they found out that if the whole body PSMA PET-CT SUV mean was greater than 10, that predicted PSA response to low PSMA. And also FDG was again found to be useful, that if the metabolic tumor volume on FDG PET was greater than 200 cc's, that was prognostic of outcome, in this case, radiographic progression-free survival, which was agnostic to the type of treatment. Whether it was cabazitaxel or lutetium PSMA, FDG PET-CT was useful in prognostication. Finally, in the VISION trial, which was the basis for the FDA approval of the lutetium PSMA, this was much simpler and operationally much simpler. In this case, PSMA positivity was required really only one lesion, and that lesion should have had uptake greater than liver, and this was visual. There was no semi-quantitation here at all. The other side of the coin was that there should have been no PSMA negativity. In other words, if there was a measurable disease on diagnostic CT as defined below, then if the uptake of that lesion was less than liver visually, then that patient could have not been entering into the clinical trial. And with this relatively simple operational scheme, they excluded about 13% of the patients, which is, as you can see, among the 3 trials here, was the least number of patients who were excluded. And this is the anatomy basically of this VISION trial. Again, total 12.6% excluded. 5% were excluded because there was not even one lesion that was showing PSMA positivity above liver visually, and then about 9% who were excluded because they had CT measurable disease but no PSMA PET uptake. Now, there is a great intra-tumor and inter-tumor heterogeneity with respect to PSMA and FDG, and this heterogeneity also is quite variable across time. These studies have shown that there is, in some patients, there is very little concordance between PSMA PET-CT and FDG PET-CT. And again, if there is any FDG positivity, that's usually not good news, shows shorter overall survival. And in Loop PSMA trial, later on, they looked at the patients who were excluded, and it turned out that patients who were excluded because of FDG positivity actually did not have they had a very poor overall survival, even if they received additional treatments. And as I said, this discordance can be temporally variable. Is it possible to predict if these patients are going to be discordant? So one study showed that if the Gleason score was greater than 8 and PSA was greater than 8, 2/3 of those patients would be predicted to have mismatch between these two PET scans and probably will not respond very well to lutetium PSMA. And if they had less than 8 for Gleason score, less than 8 for PSA, there was no mismatch. That probably means that the patients are going to respond much better. There are other non-imaging ways of looking at this, and there are reports on circulating tumor cells and neuron-specific enolase, which is a biomarker for neuroendocrine transdifferentiation, which is an aggressive form of the disease, and we'll talk about that a little bit later on. Here is again a slide from Peter Mack showing what they consider to be suitable patients for lutetium PSMA treatment. These are patients who had either concordant PSMA positivity and FDG positivity, or no FDG positive disease at all. And if they had any discordance or FDG positivity only, they were unsuitable. This other paper, this was a multi-center study, and they basically asked the simple question: if they applied the vision criteria to their cohort, which actually used a completely different eligibility, would the vision criteria be still suitable? And it turned out that in this case, actually, a vision criteria was quite reasonable. In the patients who had vision eligible, they had better overall survival as opposed to the patients who had vision PET screen failures. So this independently showed that vision criteria that was used for eligibility may be reasonable. Similar study that was also published in these 89 patients who also had their own eligibility criteria, including FDG PET, and they used two different traces here for gallium-68 PSMA-11 using liver as a reference, at PSMA 1007 using spleen as a reference because of the hepatobiliary clearance. In this case, when they compared their eligibility criteria to what would have been with vision, there was very little discordance. It turned out that only 7% of the patients would have been treated if they were using vision criteria, which of course they didn't. But and then the other side of the coin, 4% of the patients were treated in their study or in their trial, but would have been excluded if the vision criteria was used. But again, very small number of patients. This is an example of that. This is a patient who would be considered both vision eligible and with FDG and PSMA in this paper from Seifert. You can see that this patient had FDG positive disease. With vision, this patient would have entered into the trial, or be treatment with Loop PSMA, but he was considered ineligible with their criteria. And in this case, it would have been ineligible either way, either with vision or combined criteria that they used. Primarily, for example, because of this lesion here, who had a bone lesion with soft tissue component with uptake less than liver and other sites of FDG positivity. Now that brings in very interesting scenarios. Here's a patient with a lot of disease. You see in the liver, for example, elsewhere in the nose and the chest. The question would, at first glance, you would say this patient would be eligible for lutetium PSMA, but then there was this lesion in the lung, which is a measurable disease by CT, and had uptake less than liver. So technically, this patient would be considered ineligible for LuPSMA. Another similar example here is a patient with number of lesions in the liver, obviously above the background would be eligible, but then there is this one lesion in the liver, measurable disease, greater than 1 centimeter and less than uptake in the background liver visually here. Again, should this patient be treated or not? One more example here is a big node. Again, a lot of lesions which are a high uptake on PSMA PET, but this measurable node was less than liver. So this patient would be technically considered not eligible. Now, in that case, we can think of this very simple scheme that patients who have a lot of PSMA expression would be eligible for treatment with PSMA radiopharmaceutical therapy. The patients who have a lot of FDG positivity and not much PSMA activity, PSMH expression, then those patients are probably not eligible for RPT with lutetium PSMA, but there is a possibility that perhaps the PSMA phenotype can be primed and overexpressed again. In some cases, ADT, for example, may be potentially useful in that setting. And then, of course, then you're in the middle here that combination therapy may be best. So finally, with regard to use of FDG, it will allow you to really know what the tumor burden is, the heterogeneity of the disease, and kind of decide if a patient is best for combined therapy or lutetium PSMA therapy. And also even interim FDG PET-CT may be useful to see how the tumor is progressing and changing its character and phenotype. The cons on this is that, then you have to do 2 scans, you have to incorporate them into each other, and those are all not exactly still straightened out. And there may be used with non-imaging biomarkers that can accomplish the same purpose rather than using another PET scans, and also the cost associated with it. Let's talk about treatment dose and schedule modification. If you look at the VISION trial, this is the package insert. It's 200 millicurie IV every 6 weeks for 6 doses. And the package insert just says that if there is adverse events that needs to be taken care of, you can delay the treatment by 4 weeks to 10 weeks. You can reduce the dose by 20% to 160 millicurie, but if you go to 160 millicurie, you can only do it once. There should be no re-escalation. And if you have to wait more than 4 weeks, then they actually say the Pluvicto must be discontinued here. That's what it says in the package insert. But we know that there are a rare number of patients who have exceptional responses. A lot of these responses are partial, and none of them are durable. But in that clinical space, is it possible to have select patients who can have therapy holidays, for example, and especially in cases who are they have exceptional responses? And if that's the case, how do we know to resume the treatment again later on? And of course, if there is adverse events, then they should be managed just like when the patients are undergoing chemotherapy. Is it possible to intensify the treatment in some cases? How do we decide on that? And how do we decide if the therapy is failing? These are 3 papers that I think are very useful, and the one is from SNMMI consensus statement on appropriate use for lutetium PSMA. Another one is a procedure guideline, which was published in the European Journal. And then comparison of response criteria, which also was published in the European Journal, and that I think are very useful background information. Now, if you look at this case, this is a case of a patient with a lot of disease, high PSMA expression, with a PSA of 1,000. After only 4 treatment cycles, the PSA went to less than 1, and the scan looks much, much better. but how do we predict a patient like that who's going to respond with that kind of disease so fast and so good? This is another patient, a lot of disease here, received 3 cycles, PSA went down, scan get better. The patient actually had a treatment holiday here, no treatment for 6 months. PSA even went down on its own with no treatment anymore. But eventually, after 3 months after this scan, the PSA started going up, and you can see the scan is getting worse. And then the patient was started on RLT again. According to the papers I just showed you in a previous slide, this is the general consensus. First of all, you have to look at PSA, you look at the imaging, and you look at the clinical profile of the patient. The problem here is, or the challenge here is that all of these can be completely discordant from each other. But in any case, if you see a patient that has a rise only in PSA, but there is minimal radiographic progression, the patient is stable or benefiting, there is no dose-limiting toxicity, usually you should continue that treatment. If there is hematologic toxicity, that should be managed just like you manage patients who are receiving chemotherapy. And then, but if there is a patient who has a PSA rise, imaging certainly is showing that there is a certain imaging progression and the patient is declining, especially if the patient is developing liver lesions. Those are in the cases that you may consider stopping the treatment if the kidney there's a nephrotoxicity, hepatotoxicity, or unacceptable xerostomia. What we need really is a biomarker-guided therapy approach, and there are a number of papers that have been published in that space. These are all from St. Vincent Hospital in Sydney by Louise Emmett and her colleagues, showing that, for example, circulating tumor DNA gene alterations can be one useful pathway. Also, imaging after the second dose with SPECT using the lutetium gamma rays can be a pathway to decide who should have a holiday, who should have an intensification, and also the change between the first and second dose in the PSMA total tumor volume. So these are very interesting studies, and perhaps we can use these imaging and non-imaging markers to our benefit to decide who can benefit from the Lu-PSMA best. This is regarding the circulating tumor cells. You can see a patient here, for example, who had a very high PSMA expression, and then when you look at the circulating tumor cells in these patients, only 10% of the CTCs show no PSMA expression. This patient did had a very good response to lutetium PSMA, as opposed to this patient who did not have much, not a very high uptake on the PET scan. The maximum HGV max was only 20, and half of those circulating tumor cells had no PSMA expression. This patient, for example, would not be expected to have a good response. There's also nomograms that have been developed. This is a retrospective study, international multi-center, and incorporating different parameters, for example, here, and one of them is imaging here regarding the tumor SUV mean, but also the history of the patient, the distribution of disease. All that parameters can be put together to predict progression-free survival or overall survival. So these could also be quite useful. What about retreatment? There are papers coming out or have come out that show that in some cases, in some patients, retreatment, which is actually is off-label because the treatment is up to 6, it can actually be useful in some patients. But again, we have to decide which patients are going to best benefit from retreatment in this case. This is an example of this. This is a patient who started with a PSA of 519, a lot of disease, as you can see on the PSMA PET CT scan, received 2, 4, 6, and 8 cycles of lutetium PSMA. PSA went down to 2, a scan got better, so they decided to give the patient a holiday. The patient then unfortunately had a PSA rise after some time. They said, okay, let's start lutetium PSMA again, 2 more cycles. but the patient did not do very well with that. And then that's when they decided to go to actinium-225 PSMA. So what are the general predictors of extent of response to loop PSMA? The high tumor uptake is a favorable parameter. So the higher the SUV mean on PSMA PET, that suggests that there will be response. Also, the presence of extent of discordant FDG positive disease is important, as we discussed. Volume of disease is important. Low is better than high. Extent of target expression is important. Heterogeneous is worse than homogeneous. Distribution disease is important. Visceral is worse than nodal. Extent of prior therapies and that they failed, for example, is important. Tumor biology, we talked about that, and the gene alterations are important. Of course, physiological reserve. Patients with anemia are going to be relatively hypoxic, and that is not amenable to better response. And finally, two more topics: the renal impairment issue. In the VISION trial, they looked at very short time, only 30 days post the end of the therapy cycles. And in that case, actually, there was not much difference between Pluvicto and standard of care with regard to grade relatively severe nephrotoxicity. Other studies have shown that in this case, for example, 16 patients were involved who had single functioning kidney. As long as the single functioning kidney is normal or near normal function, the patients can do quite well with no nephrotoxicity. And there are a number of papers who have shown that usually this is not a problem. Serious adverse events are not a frequent phenomenon, and especially when we are talking about in the patients at a very late stage of the disease. That may not be a problem. However, this paper came out in January of this year in Journal of Nuclear Medicine that was a bit alarming, showing that in patients who were receiving more than 4 cycles of lutetium PSMA RLT, there may be some very few patients who may have relatively severe nephrotoxicity, as you can see in these patients. Now, this actually was interesting because half of these patients who had initial decline by more than 3% in the estimated GFR at 3 months, and they were followed for 1 year, they continued to have a decline in their GFR, and very few patients were followed up longer at 2 and 3 years, as you can see in here. But then, almost half again, the other cohort, which were half of these patients almost, if they did not have the eGFR less than 3%, despite more than four treatments, some of them had absolutely, very little issues with the kidney function. And by the way, this dotted line is the normal decline, age-related decline in eGFR. So when that paper came out, there was an editorial by Kumar and Hoffman, and basically they mentioned that this was obviously, and a lot of these actually were mentioned in the paper itself, that there could have been confounding factors because this was a retrospective study, and there may have been comorbidities. Patients are starting from initial insult that they had in their kidneys. There was lack of control group, and then but bottom line, the point is that we need prospective clinical trials and post-marketing surveillance in these patients, which much longer follow-ups to see what happens to the kidneys when patients receive these treatments, perhaps more than 6 cycles in the future, or when the loop PSMA is going to be used in the earlier stage of disease. Right now, this is the general guidelines or suggestions that have been made in this consensus statement, that if the baseline eGFR is less than 30 or the patient is dialysis, that should be really individualized and talked in the interdisciplinary tumor boards. If the patient has some decline initially, but it's more than 30 cc per minute, you should still use the full dose of the loop PSMA. Don't bring it down, but also pay close attention to the fact that when the renal function goes down, there is more blood pool activity, and that may cause actually perhaps higher issues with the marrow function and hematologic toxicity. And then again, from the same paper, you can see that they have eased off a little bit on the level of the kidney function and also the hematologic numbers or parameters compared to therapy trial and the vision trial. And finally, one slide on diffuse marrow disease. Vision trial excluded all the super scans. But the question is it possible to treat these patients with diffuse marrow disease? And in this study with 43 patients, which was retrospective but multi-center, it showed that yes, in many of these patients, if some of the baseline blood parameters are within normal range, you can actually treat these patients, and some of them will benefit from this treatment. So the more unsettled issues that we need to deal with in the future with additional trials or dosimetry, is it really a necessity that we can individualize the treatments, or is it a luxury? We need to come up with the final answer on that. What is the role of tumor microenvironment in the radioligand efficacy? I talked about hypoxia, but there may be other factors. Can we use AI and big data, which includes both imaging and non-imaging parameters, to be better in optimizing treatments? And of course, there's always this question about what's the best combination and sequential treatment. And I end with this slide. What is our goal? Our goal is add years to life and life to years. And as I mentioned, in many cases, especially now that this lutetium PSMA is used in very late disease, we need to be a little bit clinically flexible and really individualize the treatment for our patients as the case may be. And with that, I acknowledge my funding that I have received over the years, and I leave you with a beautiful picture of USC and fight on. Thank you.
Thank you very much, Dr. Chatwar, for giving this comprehensive lecture about the challenges of lutetium PSMA therapy. Unfortunately, we are running over time, so and it seems that there are no questions from the audience, so we go on with the next presentation, and the next speaker will be Professor Andrew Scott from Melbourne, Australia. So he's the director of Department of Molecular Imaging and Therapy in Austin Health, and leads the tumor targeting program at the Olivia Newton-John Cancer Center, Cancer Research Institute, and professor of University of Melbourne and La Trobe University. And his research is focused on developing innovative strategies for targeted therapy of cancer and molecular imaging and theragnostics. And he has actually introduced 7 antibodies which have in his laboratory, which have been licensed by the biotech and pharma all over the world. And also he was the PI actually for the FAPI imaging, which made those in clinical practice, and actually basic inventor for this, and also the PI of the multicenter trials for FDG PET with more than 30,000 patients, which led to Medicare approval of PET in cancer. And he has got numerous awards, and he has published more than 450 peer-reviewed papers, 27 book chapters, and inventor of 27 patents, and actually received more than $40 million funding in the last 4 years. And he's Professor Scott is talking about the improving access and availability of theragnostics globally. The stage is yours.
Thank you very much, Kalevi, and it's a privilege to be here. And what I'll be presenting in my talk is really looking at where we are with the ability to perform imaging and therapy as part of our theragnostics approach for patients, and some of the lessons that we've learned and very interesting data that we've generated over the last 3 or 4 years on theragnostics implementation globally, and how we hope to be able to promote that moving forward. These are my disclosures. So As we've heard from Hussein, there's wonderful opportunities for us in the radiopharmaceutical treatment of patients. The work that's been done looking at neuroendocrine tumor patients, more recently with prostate cancer, and historically with thyroid cancer, as well as local liver therapy, has really expanded enormously. But this has not been seen uniformly across all countries around the globe. We know that. Particularly in low and middle income countries, access and availability of radiopharmaceuticals remains an issue. Even in some high income countries where funding has not been fully confirmed for all of the theranostic indications, it remains challenging. And part of that is because there are different ways in which there are approvals for funding and for the use of new theranostics in individual countries. So regulatory approval mechanisms can be quite different, and increasingly health technology assessments and economic evaluations, as well as patient outcomes, are required in order to get local approvals. Compounded with that is not just access then to the radiopharmaceuticals and approval, but also the workforce and infrastructure and the education and training in nuclear medicine professionals. This will become increasingly important over the next 5 to 10 years, because we know that the incidence of even those cancers where we have effective theranostics, we do not have the capability in all countries as yet to be able to provide these therapeutic treatments to everyone who needs them. This has been recognised at a global level for a number of years, and a few years ago there was a paper that was published in the Journal of Nuclear Medicine, which was one of the first surveys looking at global access and availability of both imaging and therapeutic radioisotopes and radiopharmaceuticals. In this particular study, where initially 35 countries were able to provide their information, we looked at both the radiopharmaceuticals that were available for imaging, which are illustrated here, and of course, as you would expect, the technetium-based compounds were the most commonly used for typically bone scans, for lung scans, liver scans, and also for Mugger or gated heart pill scans as well. PET was available in quite a number of these countries, actually, and increasingly that is achieving penetrance, although the availability within low middle income countries remains challenging at the moment, principally used for cancer, but also for other indications as well. And from a therapeutic perspective, radioiodine, which has been used now for well over 60 years, continues to be the most prevalent therapeutic which is used for nuclear medicine. When this survey was done, lutetium PSMA had not been approved and was still in clinical trials, so it was only in a few countries that neuroendocrine tumor treatment was observed. But even that showed that there were marked disparities of access at that time. About 3 to 4 years ago, we then embarked on a Lancet Oncology Commission on medical imaging and nuclear medicine, which was probably the first attempt to try and understand what the true impact of imaging would have on the treatment of cancer patients, and also where we were from a workforce and infrastructure perspective across the globe. This was a very large project which involved the International Atomic Energy Agency. And in the context of just looking at infrastructure and imaging equipment, what you can see in this slide is the stratification for CT, MRI, SPECT and PET of the numbers of scanners per million population based on the income level of the country. High-income countries have over $12,600 per head of population income per year. That constitutes approximately 16% of the world's population. Whereas low, middle and upper middle income countries have income ranging from $1,000 to $4,000 or $4,000 to $12,000 per head of population per year. They constitute 75% of the world's population. And low income, less than $1,000 per year, around 9%. But you can see, looking at all of the modalities, including SPECT and PET, there's a marked disparity in the number of patients that can be treated because of the scanner numbers and the differences between high, middle, and low income. So even in upper middle income countries, there can be almost a 10-fold less number of scanners compared to those that are in high income countries. That's illustrated in this slide for SPECT, where you can see the countries in the darker green colours that actually have the higher numbers of SPECT cameras. But throughout Asia, Africa, and even parts of Latin America, very small numbers can be seen. And for PET, it's even more pronounced, where the grey colour represents countries where no PET scanners were reported at the time that this survey was done about 3 years ago. And the darker green are where you have the higher numbers. So greater than 4 per million population is seen in the US, Australia, Japan, Korea, and some European countries, but far less elsewhere. So what does this mean in terms of impact on patients? And if we want to try and get our governments and our private insurers in our countries to pay for these types of scans, which are critical for therapy, we need to understand what the impact is. So in conjunction with colleagues at the T.H. Chan School of Public Health at Harvard University, we undertook a very complex modelling of how access to imaging could impact on survival of patients, in this case with 3 common cancers. And without going into a huge amount of detail, and you can look at this particular Lancet Oncology paper if you're interested in the supplementary information, it was estimated that each year there's about 76 million people around the world that die because of cancer. But if you improve the quality of treatment and access to therapy, you can reduce the number of patients that die from cancer by just over 5 million. But if you increase access to imaging, it almost doubles the number of patients that can actually not die from their cancer. We also looked at a detailed health economic analysis, and I draw your attention just to a couple of key points here. The first is that the return on investment, if you can improve both access to imaging as well as therapy access, you can get well over $12 per dollar spent as a return on investment. But if you just look at imaging, you get a return on investment of over $170 per dollar of investment. And these are the sort of numbers that, again, governments and private insurers really are looking for as we try to convince them that they should provide greater access and funding opportunities for nuclear medicine-based imaging, as well as radiology imaging with CT and MRI. And this applies also in high-income countries, as well as in low-middle income countries as well. Well over $100 per dollar invested. And this is again illustrated in this global map, where the darker colours from green to blue show the higher return that can be achieved. And again, in Asia, Africa, and Latin America, there is a substantial evidence of return on investment for the ability to put more funding into imaging for cancer patients. Now, what are we doing with this information? Well, it is a complex task to try and get governments individually to respond to these types of analyses. And so one thing we are trying to do at the moment is work within the World Health Organization to have a World Health Assembly resolution on improving access to imaging through universal healthcare coverage, which is aimed to be promoted over the next 12 months. If this is in fact approved, it means that all governments that are part of the United Nations will in fact have an obligation to improve funding for workforce and infrastructure for imaging, which we hope to extend not just from cancer, but to other non-communicable diseases as well. Moving then to Theragnostics, as we all know, there's clearly been evidence of a marked expansion of the demand, which will increase with time. This was just from a paper review that we published a couple of years ago, showing that the principal area of expansion in nuclear medicine will be in Theragnostics over the next 5 to 10 years. And how do we address this? Well, clearly, developing the infrastructure and the workforce is critical. There have been papers that have been published in the European Journal of Nuclear Medicine and Molecular Imaging, as well as the Journal of Nuclear Medicine, on how to set up Theragnostics centres. And in Australia, we've also been able to provide guidelines on how centres should be established, how workforce should be created, and how training should be initiated as well. This has then led to another major project, which is still ongoing at the moment, where a new Lancet Oncology Commission was created a couple of years ago, looking at both radiotherapy and theragnostics, and for the first time exploring the way in which theragnostics is currently being practiced around the world and how we can undertake to improve the access and availability of these important new therapies to cancer patients. This type of Lancet Oncology Commission is really there to provide information which can lead to policy change. And so that's a listing here of all of the goals and objectives of this Lancet Oncology Commission. And in particular, when looking at the theragnostics component, which is highlighted at the top of this slide, we've undertaken a survey of theragnostics access and availability, as well as workforce. We've looked at issues that relate to production of the radioisotopes that need to be used, regulatory issues, and also minimum training standards that are required to practice theragnostics safely and effectively. And then we're in the middle of looking at a health outcome and return on investment for lutetium PSMA in patients with advanced prostate cancer. There are also components to this commission looking at radiotherapy, which I won't be talking about today, but will also follow on from a prior commission in 2015 and the impact of hypofractionation and SBRT on the practice of radiotherapy in cancer patients. We have in fact now got 6 papers that have either been published or in press in the European Journal of Nuclear Medicine and Molecular Imaging and Lancet Oncology. And we're completing, as I said, a survey in over 100 countries for workforce, access to infrastructure, availability of radiopharmaceuticals and their current use. Here we have some data which I'll be sharing just looking at the workforce, which is a separate paper which has been accepted by Lancet Oncology and will be published in 3 months' time. You can see that the number of nuclear medicine physicians per million population is markedly different in different regions of the world. And again, the challenges that we face in workforce in Asia, Africa, and Latin America are particularly noticeable. But even in the higher income countries, having people that are adequately trained for the practice of theragnostics is still a challenge and is being developed as we speak. One of the biggest areas that we identified, and which I think most of the audience here would be familiar with, is that our radiochemist, radiopharmacist colleagues are really in high demand, and the need to increase the training and the numbers of expert radiochemists and radiopharmacists to deliver the theranostic treatments that we want to be able to give has to be a priority over the next 5 to 10 years. Our nuclear medicine technologists that are essential for the imaging as well as for the therapy itself also show similar patterns of need for increasing numbers of workforce in order for us to be able to deliver these therapies effectively. And our physicist colleagues that are going to be essential for the evaluation of patients receiving therapy and also for dosimetry also will require increase in workforce over the next 5 to 10 years as well. One interesting thing which has come out of our analysis has been looking at the ability to make the radioisotopes that we need for therapy. On the left-hand side of this slide, which is a busy slide, talks about the number of reactors that are available for radioisotope production around the globe. And on the right-hand side, the number of cyclotrons, which are currently available to produce some of the PET-based imaging probes to allow us to determine if patients are suitable for theranostic-based treatments. The next slide actually shows the distribution of cyclotrons on a continental basis, probably not a surprise, but it's going to be extremely important that we look at the investments in infrastructure, not just at the local site, but also for the production of the isotopes that we need for these therapies. But a very important component of the analysis is in this slide. And I draw your attention particularly to the only reactor-based isotope, lutetium-177, although there are some accelerator technologies that are being developed by SHINE for lutetium-177 production as well. But based on the availability of full-time 6 reactors, possibly going up to 9 by the early 2030s, and their capability for production of lutetium-177, it's been estimated that we're going to need approximately 120 kilocuries of lutetium-177 to treat 100,000 patients per year with any type of theranostic modality. And the current capacity is only 204 kilocuries per year, which may increase up to approximately 600 by 2032. This translates with, if an individual patient only receives 3 lutetium treatments at approximately 7.4 gigabecquerel per treatment, of 500,000 doses per year. Therefore, in the calculations that we're doing for prostate cancer, it's quite possible that we may not be able to use lutetium-177 PSMA, even if we have approval for funding and accessibility in all countries, simply because of the total capacity that can be produced. In this context, it is quite likely that alpha particle-based therapy, which can be scaled with accelerators, may end up having a very important role in theranostics moving forward. Now, I mentioned that the training of our nuclear medicine physician colleagues in theranostics is incredibly important. And I draw your attention to this paper, which has just been published online in the European Journal of Nuclear Medicine and Molecular Imaging, which has established for the first time a training curriculum in theranostics, which was agreed by a global expert panel, which consisted of nuclear medicine physicians as well as some representatives of radiation oncology in a number of countries where they are involved with theranostic administration. And it does outline the number of studies and the types of studies that really should be demonstrated for experience in order for someone to be credentialed in theranostics. And I think this will be an important baseline document for countries to explore, as well as looking at their individual site credentialing for the safe and effective practice of theranostics moving forward. Now, one of the drivers of theranostics will clearly be industry. And this was an interesting piece of information that was published at the beginning of last year on the top 20 radiopharmaceutical companies based on market cap. This indicates that there are clearly some companies that have quite substantial funding. But even in the last 12 months, there's been huge deals that have been done with AstraZeneca and Bristol Myers Squibb. There are over 100 companies now practicing radionuclide therapy development around the world. They will be driving a lot of the innovation. But in some instances, clinical trials won't always be sponsored by industry. And we do need to be thinking about how we can develop our own networks for investigator-initiated as well as company-sponsored trials. A paper which was published a couple of years ago on the Australian experience with radiopharmaceutical therapy trials and imaging trials through ARTNet, I think is a very good reference that I would recommend that you look at. It was through the ARTNet program that the PRO-PSMA study was conducted. This was 300 patients across over 10 sites around Australia, in which it was clearly demonstrated that compared to standard imaging modalities, CT and bone scan, gallium PSMA had superior accuracy, treatment impact, and fewer uncertain results. And this was a major factor in the approval in Australia of PSMA imaging for therapeutic, for funding rather, through our Medicare advisory committees. And of course, the therapy study, which was referred to by Hussein in his talk, was also conducted across the ARTNet clinical trial network. This was an investigator-initiated study clearly showing the high impact of lutetium PSMA in terms of PSA reduction, improvement in progression-free survival, and also reduction of adverse events compared to cabazitaxel chemotherapy. And the last example, which has only just been published, and I commend to all of you to look at, which was a warmth-based analysis of the way in which actinium-225 PSMA therapy could have beneficial therapeutic effects in patients with metastatic castrate-resistant prostate cancer, was published in Lancet Oncology, one of the premier journals for any type of reporting. And I think that this is really an area that Warmth can continue to make a major contribution by looking at the way in which individual countries can combine together and sites to demonstrate the power of theranostics and to conduct prospective as well as retrospective studies in theranostics. So in conclusion, I think that there's not just huge opportunities, but clearly a lot of work needs to be done for us to be able to create the workforce and the infrastructure and the access and availability of radiopharmaceuticals to give theranostics to our patients. And advocacy is incredibly important. There are huge numbers of data sets now available that can be used for countries for submission to their regulatory authorities. And Warmth, I think, has a key role to play in this advocacy, training, and generating new data for theranostics. Thank you.
Thank you very much for the excellent overview about the access and availability of equipment and tracers and personnel. So we are type of running out of time, but I don't see any questions from the audience, but because we have had very excellent talks from two distinguished speakers. So I want to ask a question from Andrew first. So you know the development in the field of new theranostic agents like Lutathera and Pluvicto and trend in this. So those extensive studies what you have performed globally. So what is the difference? What kind of trend you see in the improvement of getting new equipment and tracers and all these infrastructures? You didn't have any trends, but how is your feeling about the trend? What is happening because the world is very uneven in this perspective. So can you briefly comment on that?
Yeah, so I think that we know that healthcare delivery is very inconsistent between countries around the world, and the income level of the country will clearly impact on the access and availability to the population. In many countries, if you have the personal funds to be able to pay for theranostic treatment, there will be private sites that can actually provide that. But what we need to be doing is looking at ways in which we can have more cost-effective delivery of these therapies, and also ensure that there is enough lutetium-177 PSMA to be available to all the patients in all the countries, for example. So I think that advocacy, both at a country level as well as through WHO, is important. I think the International Atomic Energy Agency has a very important role to play in engaging with governments. But I think all of us in our individual countries have a role to play in being able to educate our clinician colleagues, government, as well as the hospitals. And we should be working together so that if more information is required to justify investment in theranostic centres in a country, as part of the collective Warmth family, we should be able to help each other to provide whatever data we have used in order to get the infrastructure in our sites and in our countries as well.
Yes. There's, I see a question from the audience that the role of IAEA promoting nuclear medicine. Can you comment on that?
So the International Atomic Energy Agency, I think, is a trusted and respected player in the world stage, and governments do listen to when the IAEA provides recommendations. And so that's why, for example, the minimum training standards white paper, which I showed was recently published, is so important, because it's seen to be an independent group of experts that can provide that advice to individual governments. So I think that's an important role that IEA can play in policy and giving advice.
There's also a question about radiobiology in kinetic theragnostics. Can either of you comment on that?
Well, I can start the answer. Well, I mean, radiobiology is obviously very important. You need to get the radioactivity to the target, as we're trying to do with Theragnostics, but at the same time, the radiation sensitivity of the cell itself, and all the tumor biology, as I mentioned in some of my slides, is extremely important. The different the gene alterations can make the cell more resistant to any type of treatment, including radioactivity. And so understanding all the intricacies of radiobiology and tumor biology itself is very important. And I think there are some strides to that end, as we already saw.
Yeah, I have one question to you, Torsten. So you presented a very, very excellent overview about the different trials. So this is from the clinical practice point of view, because I've been treating a lot of patients with all these agents, and now the question is that where would you draw the line in clinical practice if you have like PSMA, a lot of late advanced disease with a lot of PSMA positive disease, and also some let's say many lesions which are FDG positive. So how would you postulate this? How should you treat this? Because you have to treat all the patients.
Yeah. It's a rather difficult question to answer, but as I mentioned, right now the way that we practice, let's say at least in the U.S., we don't do FDG PET scans in these patients, so we just have what we see. That is PSMA PET CT, and in many cases the scan appearance is such that you feel that the patient is going to be eligible for treatment. You as long as there is no measurable disease that does not have any uptake above liver, below liver. But the question is, as I showed you, I think in some of my slides, there can be situations that you just blind to what else is going on. There may be smaller lesions that are FDG positive. They're going to be resistant to this treatment, the Lu-PSMA treatment, and you wouldn't know it. That would be one of the reasons that you see some of these patients may have delayed response or not a very robust response. So we're just we're basically looking at the patients we are getting into this treatment with a fuzzy picture of what is going on with the tumor in that particular patient. So as we understand better, either through imaging with different tracers, including FDG if feasible, and other non-imaging biomarkers, we may be able to be really good at stratifying and selecting who's going to be the best candidate for what kind of intensification of treatment and what the schedule and all that. So optimization of a schedule and dosing and type of patients and type of tumor, these are all things that we all look forward to in the future.
Okay, so we are exceeding time. So there is also that there are other global organizations. There is like World Federation of Nuclear Medicine Biology, and also WHO, which have nuclear medicine presentation. But we are exceeding our time, so this was type of 5-year anniversary of the first World Theragnostics Day arranged by WOMT, World Association of Radiopharmaceutical and Molecular Therapy, and we will have this kind of event next year. We don't know the exact date, and we have had hundreds of listeners. So I'm very pleased that we have that we have had this wonderful event with very nice presentations and distinguished, excellent speakers and very informative talks. And we have I'm closing the webinar with this word. Thank you very much
Thank you very much.
Yeah.
Thank you. Bye-bye.
Good night. Bye-bye.